Dr. Fikri. It's a pleasure to be with you. I don't think I can tell you all about lipids in 15 minutes, but I'll try my best. So the total cholesterol is a composition of multiple lipoproteins. And as you can see here, they are identified by receptors that reflects their function, whether ApoA, ApoB, as you see. And their content is primarily triglycerides or cholesterol. Now, some of those, as you know, the HDL, and then we have the other components, which are all atherogenic except for the HDL. So I think this will be touched on sometime in this conference. It's a good idea to look at the non-HDL, which really reflects all the cholesterol minus the HDL, which gives you a much more global sort of assessment of the burden of cholesterol. But the story is more complicated than that. I think we have multiple LDLs, multiple HDLs, and they have different impact on atherosclerosis. I think we look at one LDL. As you can see, you have small, dense LDL, large, and there is Lp(a). Now, to look at the impact of the total risk, I think you need to look deeper. So it's LDL, the oxidized LDL, which is responsible for the plaque rupture, small dense LDL, Lp(a), triglycerides, homocysteine, and hCRP as a reflection of inflammation. We've been doing this for years. This is 2016. I measure in certain patients, I measure the global look. Here, this patient has homocysteine, hCRP, and these are the LDLs. You have multiple LDLs. Now, as you can see, small, dense. So regular large LDL is less, has less impact on atherosclerosis than this small, dense LDL. So in certain patients with strong family history, it's important to look at these aspects. I think the intervention over the years has been fascinating in the lipid management. We have the statins, we have the ezetimibe, the bile acids. I think there are newer interventions like the bempedoic acid, which is a step up of the cholesterol outcome. You have the PCSK9 inhibitors, and then we have newer agents. Ivanizumab, this is a monoclonal antibody that works both on triglycerides and statin. So I think there is a huge exploration in this field. But I have to say that the statin trials have really made a big impact over the years and still do. And some of them have been placebo-controlled, and then comparing to dosage versus adding ezetimibe or adding PCSK9. And I'll just show you over sort of very quickly. So initially, it's primary versus secondary prevention. These are the initial two major trials, the 4S for Sinva, West of Scotland, primary prevention. And as you can see, the initial LDL was quite high in those patients initially. And there's significant reduction with impact on outcome. And then these are the trials that were versus placebo. And then it was unethical to do placebo. So the PROVE trial looked at low potency statin versus high potency, Prava versus Atorva, significant reduction. Again, much lower LDL to start with and an impact. Then we looking at dosing, 10 Atorva versus 80. It's not exponential benefit, but definitely there is a significant impact on the higher dose, and as you can see, TNT. And then adding a non-statin to a statin regimen, and ezetimibe, a little bit of improvement, not very impressive, but still, and again, you can see improve it. And then you have the Jupiter, which I think I like this trial a lot because it adds layer of benefit of statin. This is a primary prevention, big trial, not very high LDL, but those patients have high CRP. They have inflammation. And with 20 milligram of Rezuva, look at the impact on reducing outcome 44%. This is one of the highest reduction any statin has made on a trial. Small dose, not very high LDL, so inflammation is key, and I think that adds to the mechanistic benefit of statin. It's beyond LDL, it's vascular benefit, and I think Jupiter clarifies this very well. So Jupiter pushes it, now we have LDL of 50. See, it's progression guided by outcome. Personally, I don't think it's that important to lower for the heck of it. No, this should be equating to outcome. So the question is, what's next? And because despite the immense benefit, there is still a lot of residual risk left. With Jupiter, about 56. So where is this risk going? And then we start having the PCSK9 inhibitors. And I think this is a fascinating area. There's a lot of work working on. There are about 8 interventions with the PCSK9. But as we know it, there are 2 medications already in the market. The one is working in the actual receptor. This is blocking the PCSK9 on the LDL receptor, preventing from damaging to the receptor. And that's given twice weekly injection. And then we have the more of a nuclear long-term inhibition of the synthesis of PCSK9, and that's given twice yearly. So I think these 2 interventions have really pushed the envelope. Did it make a difference? Well, these are the 2 major outcome trials, Fourier and Odyssey, as you know. These patients were fully treated. The majority were on high-intensity statin. Some of them are on ezetimibe. So they have maximized the benefit and significant impact on LDL in both trials, and some benefit. I mean, I think if you look at the range of LDL reduction, you'd expect much impressive outcomes. Still, it's quite significant, about 15% relative risk reduction. And then you have the inclisiran, which is the much more longer acting PCSK9. Again, very impressive reduction in LDL. There's no outcome yet in this trial. I think the benefit is similar as far as LDL, but it's much longer. So I think we have to wait to see what is the outcome. I don't think it will be that different, but still safety, because you're giving an injection over 6 months, and then we need to see how patient will tolerate that. There is no more news. There is an oral PCSK9. This is presented at the last American Heart meeting, and 65% LDL lowering. It's even more than the current PCSK9. Whether oral is a better choice than injectables, I personally think it's a good idea to have the injectables. It makes life much easier, but still, I think this is an evolving concept. I think triglycerides have been ignored for a long time as a major independent risk factors. These are the original trials done on triglycerides, which didn't show any benefit. But if you look at the sub-patient population analysis, if you take those who have high triglycerides, there is some benefit. Still, in some of the guidelines, it didn't even make it that you need to try and treat triglycerides. Until recently, the Reducer trial, which really used a high dose of omega-3 equivalent ethyl 4 milligram in patients who are already using statin, and there was a significant impact on those patients who received the treatment over 5 years, and with very high p-value and a very good relative risk reduction. So that really puts the impact on treating triglycerides on the map. I have to say, and I've used it extensively, there is some risk of atrial fibrillation. I personally had 2 patients, so you have to be aware of this. And recently, there was an issue in patients with post-PCI who were on the dual combination. It didn't achieve significance, but they may have some bleeding issue. So one has, because part of the omega-3, that they increase the bleeding aspect of patients. So that is something that we need to look for. But I tell you, it's a very effective intervention in patients who have very high triglycerides. So I think it's not about LDL, it's not about cholesterol, it's not about triglycerides. It's a I mean, if you suck out all the lipid, I don't think you will reduce the risk to zero. So it's a combination. Inflammation is big. I think COVID has told us that, and actually most of the diseases start by inflammation. And colchicine is a very interesting concept. So inflammation and measuring hsCRP, not the regular CRP. I didn't talk about Lp(a) because that takes a whole lecture. This is an atherogenic and thrombogenic particle. So it has the dual impact of having atherosclerotic impact and thrombogenic, and we have medication for it now. We have newer therapies for reducing LDL, and we have newer intervention in triglyceride. So it's really a combination of multiple interventions in those medications that has outcome benefit as such. And this is a small list of what is coming up. Now we have, it's all going through the nucleus, and I think most of what we are going to have, it's either monoclonal antibody or an injectable that acts on the nucleus, and subsequently, as you see, a combination of reducing triglycerides and cholesterol, 2 medications for Lp(a), which are already out, phase 3 trials. So let me finish by re-stressing that lowering LDL is effective with statin, ezetimibe, PCSK9. We have newer medication, pemphigoic acid and inclisiran, which are not have outcome. Lp(a) and newer triglycerides medications are very important. We have new treatment target. I think we're more focusing on actually blocking the synthesis of some of these aspects. And eventually, you need to individualize your treatment. I think every patient, unfortunately now we have a very generalized picture of lipid that literally everything works. I think you have to check more, you have to do more differential aspect of the lipid, and therefore specify your intervention. But most importantly, it's incremental benefit. I personally, doesn't impress me if somebody tells me that LDL is 50 or 20, fine. Does it translate into outcome? Because we're talking about cost, incremental benefit, and the complexity of the disease. Thank you very much.